Okay, we'll get started. Welcome, everyone. Happy Friday. We're so excited to have you here today. It's going to be a wonderful conversation, a lot of learning and sharing. I'm Lori Kehoe. I'm a member of the outreach team at SunCloud Health, alongside my colleague Donna Bartlett. She's not able to be here today, but she's my colleague and works directly with me and Renee on the CE series. SunCloud Health provides integrated, nuanced treatment with residential, PHP, and IOP for adolescents and adults, and virtual services for adults in Naperville, Northbrook, Lincoln Park, and now Matson, Illinois. If you're interested in updates about our program and services or would like to schedule trainings related to professional development or parent or student workshops, please reach out to Donna or myself. Our contact information will be included in the last slide for your reference. And of course, to make a referral for one of your students or your clients, you can certainly reach out to Donna, myself, or Renee directly. And now I'd like to introduce our esteemed presenter today, Bonnie Lane. Bonnie is a graduate from the National Louis University with a master's degree with honors in both developmental and counseling psychology and a master's degree in special education. She is also a certified mediator and a certified domestic violence counselor. Bonnie served as the program director at Youth Services of Glenview and Northbrook for 6 years. Among her responsibilities was facilitating groups for parents of children suffering with bipolar and schizophrenia. She was also the executive director of Project Hesed for the JCCs of Chicagoland, and she served as the executive director of Wilmette Youth Connection. Most recently, Bonnie worked for Threshold's Community Mental Health Agency as the team leader for all case managers in the youth adult program. For more than 2 decades, Bonnie has worked privately with families dealing with severe mental health issues, such as schizophrenia, schizoaffective disorder, bipolar disorder, and substance use disorder. She has counseled individuals and families as they successfully navigate the maze of care and resources available for adolescents through older adults. Helping families in times of crisis is her mission and her passion. Bonnie is currently a member of the NAMI Illinois Legislative Committee, NAMI CCNS Board, and the North and Northwest Suburban Housing Task Force. Bonnie also sits on the Healthy Minds, Healthy Lives Coalition through Thresholds and the Mental Health Summit. Bonnie is a board member of No Shame on You and serves as their program chairperson. With No Shame on You, Bonnie facilitates twice monthly support groups for families of seriously mentally ill at no charge to the community. And without further ado, I introduce you to our esteemed speaker today, Bonnie Lane.
Hi, and thank you, SunCloud, for inviting me. Thank you, Renee, for inviting me to participate in this wonderful program. As Lori said, serious mental illness and addiction is my daily work. But I wanted to talk to you before we begin the slides on serious mental illness, talking about schizophrenia and bipolar in young children. The youngest documented case of schizoaffective or schizophrenia is Janie Schofield, and she was only 7 years old. Childhood onset of schizophrenia often develops in premorbid abnormalities, displayed as introversion, depression, aggression, hallucinations, suicidal ideation, delusions, manic-like behaviors, disorganized thinking and speech patterns, abnormal motor patterns, diminished interest in school and social interactions, anhedonia, which is an inability to find pleasure or experience pleasure in daily life. While it usually appears between 16 and 30, you can see it as young as 7 years old and sometimes younger. The hallucinations and delusions that are present are frequently misdiagnosed as imaginary play in children, So it's something that it's difficult to diagnose. Studies show that 4% of people under 18, as young as 5, have bipolar disorder. To put that in perspective, 9.8% of people, of children experience ADHD, so it's not that much lower. In young children, it's usually called cyclothymic disorder, or you may have heard of rapid cycling, going from manic to very depressed. Um, it's usually cyclothymia is a mild form of bipolar, frequently misdiagnosed as ADHD. The other, or DMDD, which is disruptive mood regulation disorder. Adderall can trigger mania in young children with bipolar or misdiagnosed with ADHD. Adderall or any other stimulant ADHD medicine. It's always recommended that a mood stabilizer be offered before an antidepressant or a stimulant. The mood disorders that you may see are DMDD, disruptive mood, bipolar, ODD, oppositional defiant disorder, ADHD, you all know what that is, attention deficit hyperactivity disorder, with or without hyperactivity, anxiety, IED, internal intermittent explosive disorder, MDD, major depressive disorder, conduct disorder, which can grow into oppositional defiant disorder. It's frequently misdiagnosed as ADHD. So if you see, according to the DSM, when there are 12 possible symptoms and you see 7, it's good to refer your patients, clients, students to a psychiatrist to determine if bipolar or schizophrenia is in the premorbid state. We can start with the slides now. That's just a little history. Access to resources post-hospitalization. If a student that you're working with is hospitalized for psychiatric crisis, transition planning to post-hospitalization treatment needs to begin during the hospitalization. You can speak with the school social worker, the school psychologist, or an independent advocate to determine what level of care is appropriate post-hospitalization. Coordinating academics while prioritizing treatment is very important. So we need to know what level of care is appropriate, and we support students academically in treatment throughout the transition in any level of care. Inpatient being residential, inpatient being hospitalization. You can attend school while hospitalized. There are a number of university-based hospitals that offer students to remain in the hospital and attend school in the residential level of care. Residential would be stepping out of the hospital and going to either a residential program with education or doing a therapeutic school where they have treatment. Those are two different things. The ways of paying for them, though, is vastly different. Residential treatment with education is supported through either private pay, commercial insurance. Those are the two ways to pay for that. Residential is paid through commercial insurance or private pay. If you're going to a therapeutic school, then you need to work through your school district. Usually an advocate is recommended to attend school meetings with you, school staffings, and then they will encourage the school to pay for the therapeutic school. They can be all over the country. The school district usually likes to try an off-campus or day program therapeutic environment through their own district before they will approve residential out of district for them to pay for. Most school districts do have this as an option, and it's a good place to start. You will then be continuing to see your outside provider for psychiatry and therapy. But there is a different education to treatment ratio. If you're doing a residential program with education, you usually have education about 1.5 to 3 hours a day, sometimes less, and not every day. If you're in a residential school program, you will have education for half the day and therapeutic clinical interventions and treatment for the other half of the day. You also have the opportunity for experiential treatments such as equine therapy, art therapy, music therapy, and other community-based modalities that are available. Um, when you're talking to the hospital, the psychiatrist that is treating you inpatient can help guide you to what they believe the next appropriate level of care should be. And as the school social worker or the private therapist or the school psychologist, having a collaborative rapport and relationship with the hospital is very important. Make sure that you discuss this with the families so they know that you would like to be involved in the transition planning so that you can make sure that all of the needs are met once they return back to their home school. It is a team approach. Collaboratively, you need to work with the hospital, the school, and whatever placement they will land initially. The initial placement is not necessarily the final placement. If the school district recommends an in-house, meaning a connected therapeutic school environment, that may not be successful. If it isn't, you can have a failure and then you go back to the district where you request a higher level of care, meaning a therapeutic school where your student will not live at home, but they will receive their academic equivalence, usually through a program designed by the homeschool so that they can keep up with the academics that they could be missing. Students can frequently re-enter school at the same level that they left. Occasionally, they do lose some hours if they have school refusal, either at home or in a residential placement. It's not uncommon that when a student goes to residential, initially they may refuse the academics because they're so dysregulated, caused by their serious mental illness. Virtual academic resources are also available if your student has school refusal and they are able to be treated at home by a psychiatrist and therapist, but they are not willing to attend school for a variety of reasons, a mood disorder, a thought disorder, social anxiety. They could attend school virtually. If you remember during COVID, every school set up a virtual arrangement. These virtual arrangements may not be directly through your school, but they will be hired by your school to give you the opportunity to have your student participate in virtual education. We are always moving toward the goal of returning a student to school full time with in school support, as well as psychiatry and therapy out of school support. You can also do a PHP or IOP, which is partial hospitalization, which is the longest period of time in treatment outside of school. The PHPs usually do offer an educational component. Some of them do allow you to participate in a PHP during part of the day and go to school for part of the day. The IOP, intensive outpatient, is generally done that way, with you attending IOP after school for 3 hours and doing academics during the school day. That's a great mix for a student that is willing to go to school and wants to be in school, but still needs a higher level of care than an at-home psychiatrist or therapist could provide. navigating local resources, considerations when recommending a higher level of care. The primary concern is what does your child need to be successful returning back to the school? What do they need to be successful in managing their symptoms independently? What do they need to be successful in academics and mental health? So we need to consider all of that when choosing which higher level of care is appropriate post-hospitalization. It's very, very rare that someone could go from a hospitalization to directly back to school. There are great children's hospitals in the community and in every community where they will help guide you to determine what's appropriate. We also look at the presenting symptoms. If somebody is seriously bipolar, as I described before, let me finish my sentence and then I'll read the question. Um, when considering presenting symptoms, you have to note the severity of the symptoms. Um, Children, adolescents, and teens are rarely hospitalized, even adults, without a serious mental health concern, frequently suicidal or homicidal ideation, severe mania where they cannot control their cyclical mood cycles, um, or psychosis, being a hallucination or delusion that they believe is real. So the question is, what are your suggestions for school staff supporting families who struggle with maintaining the outside support, psychiatrists, therapists, and have a hard time delineating between what the school has the capacity to support versus the level of therapeutic support that is necessary to support them in getting back into school? Yeah, collaboration is very, very important then. I would always recommend a meeting with the parents and the outside treatment team, as well as the school treatment team, so that everyone can and very clearly identify what their role is for the school. Parents that are in distress with children that are seriously mentally ill or struggling with symptoms reach out to whomever is available, and the schools are usually a lot easier to get a hold of than their private outside psychiatrists and therapists. You can reach out with a release of information to speak to the outside providers and explain what the parents are asking you for and ask them for recommendations on how they will be able to support it so that you can share this with the student. There are very delineated roles, we know, and the school does not do everything that an outside practitioner can do. You can, however, refer your students to neuropsychological evaluations to determine diagnosis, and you can put things that are naturally present within the school, such as quiet time or accommodations that have been determined by their 501(c)(3) or their accommodation report. Did that answer the question? I don't know. Um, Collaboration. The answer is just have a conference with the school psychiatrist and therapist where you can explain the level of supports that you're able to offer and what needs to be handled before they re-enter school. When looking at a higher level of care, the primary concern, of course, is addressing the symptoms in the best possible way, providing whatever is possible to lead your student to success. Um, you do have to consider parent input, and not all parents are ready to send their child to a therapeutic environment or even outsourcing their mental health care. So, working with the family, you can refer them to a family counselor or a parenting coach who can all help explain to them that even though this seems difficult right now, the goal is to have your child stable so that they can re-enter traditional school sooner. Um, If you're dealing with an unusual family dynamic or one where it is two divorced parents who are both making decisions on behalf of the child, it's important that you communicate with both of them. If it's impossible to do a family conference with both parents, then I guess it's incumbent upon you to individually explain to each parent what you are recommending. And if you can send it out in an email to both of them, that would probably make it easier for you. You need to explain what they can expect from the school and what they can gain from using other resources. Um, Affordability and access to care. So, psychiatrists, therapists, and programs, if they're therapeutic programs like SunCloud, do accept insurance. They accept commercial insurance. Um, it's not on my notes, but this is open enrollment. It is time for you to look at your insurance card, contact your agent, and make sure that you have coverage for whatever may come your way in the next year. Every policy is different. Every PPO, HMO, or affordable care plan is different and offers different things. You also have to consider access to care. If you will not be able to get your child to a PHP or IOP every day because of a work schedule and other children, you may want to look at a residential program for your 12 to 13 to 22-year-old student. Um, there are programs that are residential for littles. Um, I don't often recommend them unless it is the only and best option to get the child the level of care they need. So, affordability, access to care and transportation, check your insurance. It's open enrollment. We need to look at that now. Make sure that you have access to the resources that you may need. Doesn't mean what you need today. If your child is currently seeing a psychiatrist to manage meds, a therapist to manage moods and thoughts, then it's a good idea to make sure that you have access to mental health care. And you have to look at also what your maximum out of pocket is. There are policies out there, and you think you have a great policy, but they have no maximum on your policy, which means after you pay your deductible, the family would still have to have a lot of out of pocket expense. Make sure that the policies, have them look at their policies to make sure that during this time they have an opportunity to upgrade their policy so that the level of care that they may need in the coming year is covered by insurance, because although private pay is available, it's costly. So, long term residential versus housing. Um, Before your child is 18 years old, there is no housing available. Should they leave school at 16, they're unable to go to school, and you think that they would be able to just find supported housing, it does not exist under 18. In most cases, you'd also need to have your child, your adult child over 18, on Medicaid and Social Security. And the right time to contact a Social Security advocate, one that can help your child get on SSDI, is before the age of 21, when you have documentation of the disability that has impacted their lives and hospital records and doctor's reports. Um, Long-term residential, though, is available from 13 on, and I told you, and in some cases, even before that. Long-term residential is not housing. Long-term residential lasts 45 days all the way to 11 or 12 months. Um, it will not all be covered. Okay. Um, they will not they will not be covered by insurance beyond what your insurance permits. I want to just read something. So if you're dealing with a family that you think may need a higher level of care, please direct them to an insurance agency that they can find on the back of their existing card to make sure that they have access to the level of insurance that they may need. Um, you can refer to residential. You will not be referring to housing. That won't be your world. That's usually post-academic. I also recommend people that do have a significant disability to not accept their diploma until the age of 22. Parents are anxious. They think that they're finishing school and their problems are over. The problem they encounter then is that if the student accepts their diploma before 22, their resources also dry up and they will not have the ability to participate in a transition program. And the transition programs are provided by the secondary education facility if you're already in a program. Transition programs are done by diagnosis, serious mental illness, intellectual disability, and developmental disability. Um, Also, if they are neurodivergent and they struggle with autism. So there are different paths that your families can be directed to by you, depending on what resources they need. If you have a question, feel free to reach out to me about what the appropriate path to take. Once somebody is 18, there are a variety of housing opportunities that they need to apply for while they're still in school if living at home is not the best option. There are Community Alternatives Unlimited is the agency that manages post-education housing and services. Community Alternatives Unlimited. You can direct your family to call them and get get their loved one on the PUNS list, which is the list that puts them on a list for permanent supported housing for their lives. The list is long. It usually takes about 4 years to get your name called. That's why I recommend that while you have a student still being seen by you in school, it's a good idea at that time during the transition program to apply for the PUNS list through Community Alternatives Unlimited so that when they do transition out of secondary education, they will have an option for supported housing. Supported housing looks all different ways. Some are buildings, group housing, some are subsidized housing without link services, and some are CILAs, Community Integrated Living Association. If your family is able, they can also purchase a house and link it to an agency to form their own CILA with residents that are similar to their child to help defray costs of a house manager and the mortgage. You have to guide your families to make a decision based on their needs, their finances, and the diagnosis of their child and the severity of the diagnosis. All of these come into play when determining what post-secondary will look like, but we start planning these long before they graduate. So your job is not to find the programs for them, but to guide them to the resources that will be available post-secondary. That was more or less what I wanted to talk about. I wanted to talk to you about the options and mental health challenges that could face the students that you're dealing with. The options are varied. They come at all levels of care and are paid through a number of different financial streams. Um, your job would be if you notice a significant mental health issue, a developmental issue, an intellectual disorder or neurodivergence to educate the families on what they may need to look for moving forward or recommend resources in the community where they can get their needs met now. Um, and explain to them that leaving school is not a permanent solution. It may be what they need for now, but your child will be able to re-enter once they are stabilized. Um, if your school offers a variety of resources, as I'm assuming most of them do, I would also connect your family with whatever resources your school district offers so that the students can receive services in the school. If your school does not offer resources that you feel are appropriate, you can refer them to resources outside of the school, either for a period of time or permanently. Um, Families can reach out to me if they are considering a residential level of care, a partial hospitalization, or um, an IOP, an intensive outpatient program. Families can reach out to me for guidance and support. I not only provide the referral, but I work in tandem with the hospital to make sure that appropriate referrals are made. I work with facilities that treat children, young adults, teens, adolescents, all around the country and appropriate for oral insurances. I'm very intentional when choosing a facility. The diagnosis is very, very important, and every facility treats different diagnoses. If you're a high school practitioner and you're noticing a substance use disorder, I also work with families who have adolescents that are struggling with a serious mental illness and substance use disorder, or a substance use disorder that looks like it's standalone, but you believe there's probably an underlying mental health concern. Um, I also work with families to do parent coaching. I will be able to help parents set boundaries, find resources, and communicate effectively with their children in language that they will understand. Stress makes our words come out wrong. We say things that we don't really mean. And if your student is neurodivergent, they may require black and white speaking. If they're dealing with attachment reactive disorder, they may not have trust. So I will help you communicate with your student, with your loved ones. And the social workers and psychologists on this call, please feel free to also call me at any time or reach out to me for any resources that you'd like to discuss that your student may need. You can refer them to me to present the resources, or if you just want to be able to do a conversation about resources that exist in general, I'm happy to help you frame that in a way that's not threatening.
Bonnie, could you also talk more about, when our school social workers are trying to get resources, especially for the kiddos that have Medicaid, are you able to help families navigate resources for them?
Oh, absolutely. Um, there are Medicaid resources. Most of them are hospital based or community based. Um, there are a lot of local mental health agencies that also accept Medicaid. You can look for mental health agencies in your community based mental health agencies. Some of them are even residential, providing group home living for high school age students through 22. So they will either do the treatment there and provide either group home living or living within their facility, or community based living with supports, or they can just provide you with therapy and psychiatry that can be paid for by Medicaid.
And then Megan has a question. She says, we have a large school, and when a student has been identified for further evaluation and then ends up in the building sometimes the next morning with no communication from family or other outside entities, what is the best practice for the school to follow to provide support and safety? This is a two-part question. I'll let you answer that part first.
Okay. So when you refer them for outside evaluation or testing, I'm assuming you're referring them to a provider you know. If you're not referring them to a provider you know, and even if you are, the parents need to sign a release of information, and students 12 and over need to sign their own release of information to share information. I know that sounds harsh, um, because if somebody is already dealing with a serious mental illness or intellectual or developmental disorder, the fact that they are charged with the responsibility to sign their own releases of information seems unreasonable, but it is the law in the state of Illinois, and it has been since 2018. I mean, 2022. The law was changed. It was 18 and over, and in 2022, the law became 12 years old and over. So you tell the family when you're making the referral at the original onset, if possible, to sign in a release of information for you to communicate with the provider or the tester. If you didn't do that, you can go back to the family and say, we really want to help your student in the best way possible. And we can't unless we have access to the reports. And so you ask them then to go back to the provider and sign this release of information. And then you can contact the provider directly to request all testing and reports that were given so that you see what the diagnosis and assessment showed, so that you can then work appropriately within the school to provide resources that are needed or refer them to outside resources if necessary.
And then she's asking, in addition, why are there no expectations or more education to have a reentry meeting after these instances, especially in the emergency room? Aside from telling families we can follow up with DCFS, if they do not follow through with these supports, which does not build relationships.
I agree. Trust is the most important thing. You need to have a relationship that is strong and communicative with the family that you're dealing with. So um, you can make it your school's practice that the student will not be readmitted without a reentry meeting. You have to put that in the school bylaws, though. It has to be your mission statement. Um, Otherwise, if you are not offering that, then the hospital will not know what your standard practices are. So they will not be scheduling something. So it's most important that you set up a process for reentry, which involves discharge paperwork from the hospitalization, even if it was just an emergency room visit. That way, you know what the emergency room saw, what they diagnosed at, and what they recommended. If they recommended that the person then sees a psychiatrist for medication management, you then can enforce that and say reentry will not happen until we see that a scheduled appointment is on the books. You can't expect them to have already seen the psychiatrist, but you can expect them to have reached out to a psychiatrist. If they don't know a psychiatrist in the community and you don't have any resources for one, please feel free to reach out to me for a list of psychiatrists that will be able to get the student in to begin on medication.
And then Ava is asking, can you clarify how to support families who may need the services, but due to their insurance, they don't qualify for coverage, or what services are available for families who are not able to pay out-of-pocket costs?
So that's what I said. You look at your insurance card now. Now is the right time to recommend that families check their insurance card. And you may even want to send out an email blast to your community if you're permitted, saying, remember, it's open enrollment. Make sure that your insurance is covering what you may need in the next year because parents think I have insurance. They don't know what their coverage is until they need it and find out that it's not covered. Um, if they're on commercial insurance, this is the time to look at it. If they're on Medicaid, I also recommend that you contact your that you recommend that they contact their local hospital. Not all Medicaids are equal. Find out which Medicaid your local hospital accepts, and you can refer them to contact Medicaid directly to change the Medicaid to a different Medicaid provider. There is managed Medicaid, which includes Blue Cross Blue Shield, Illini Care, County Care, Meridian. And then there's also something called straight Medicaid. Straight Medicaid is one that is least likely to be accepted, but changing your Medicaid is literally just a phone call. So you can tell the parents to make sure that they have checked their Medicaid card um, or their commercial insurance card. And if it is Medicaid, to call their local hospital to see what Medicaid they will accept.
And then we have a question from Allison. I'm a social worker at a high school, primarily over the alternative program. I'm advocating for more transition programs within our school, but currently doesn't have anything in place, trying to identify work study opportunities, internships, etc., by not collecting their diploma until closer to their 22nd birthday. Do you know of any federal funding that may support these types of transition programs rather than referring out?
Um, that's a really good question. And I'm sorry, I don't know, but I do know that there are high schools in the area that have some really good transition programs. And I'm sure that if you called Deerfield High School, for one, has an excellent transition program. Um, Glenbrook North has a good transition program. If if you are in a school that does not have a transition program, call one of the schools that does. They would be able to direct you. I'm sure they'd be very happy to share the resources that they use to get funding. If it's not a funding issue, but it's just that you don't have the program in place, then that's an issue for the school board. And go to a school board meeting and advocate that you need more resources for students that are going to be transitioning. There are even schools like Rolling Meadows High School that offers certificate programs while the student is still in school so that when they matriculate, they already have received a certificate in nurses aid or welding or a number of different tech fields so that if these students are not college bound, they still could get a job afterward and they'd be learning and having an internship while they were still in school.
Okay, thank you. One more question. Are there any suggestions of how schools can restructure their teams to be able to have time to communicate to the degree that may be needed? I often find that before students move to a higher level of care, our school staff may not be able um, may not have the capacity to respond as often and as quickly as parents would prefer, which can impact the trust even when there's not malintent and can create barriers with communication down the line. I specifically feel like this happens when students are struggling, but the family is not ready to seek a higher level, often leaving the student and family in limbo because improvements are not happening.
Yeah, that's really good. And you're right. You can't wait for conferences to have this conversation. And I know that teachers work so hard and they don't have enough planning hours, and social workers work so hard managing a student body. Um, it would be ideal if when you meet with other teachers, with the school district, with the superintendent, that you request that there is at least an hour a week that you can keep open for students in crisis, for parents that are in crisis to return calls. And then you explain that to the parents that this is when I'm available to talk to about what's going on with your student. But you are showing them that in good faith that you are giving them a certain amount of time. Um, I know that it's a really hard ask with the caseloads that you all must be carrying. And sometimes it's best, even if they're not ready for a higher level of care, to refer them to an outside therapist or psychiatrist that takes their insurance or Medicaid that you can collaborate with so that you can do it via email with the outside provider. And you can provide all of the information to them and explain to them that you can, to the families, that you are only available by appointment unless it's um, a crisis,
Mhm.
not just a daily occurrence of dysregulation or dissatisfaction.
Mhm. And when you have those students that you need to refer to residential, you know that you can call either Donna, myself, or Renee or Bonnie. And because we now have that level of care at SunCloud. And if SunCloud isn't the right fit, we are here to support you and help you find a resource. Any
And
other?
I'm all, yeah, and SunCloud, I will tell you, is a great resource, and I refer to SunCloud regularly. I'm in the process of referring two people to SunCloud right now for different issues at different ages. And SunCloud offers a variety of treatment modalities. And if your insurance is not appropriate for them, or you feel that you need something else, if your child has a disability that is not met by SunCloud, or it's not in a location where you can easily travel there, um, and residential is not your option, SunCloud will refer you to an appropriate placement, and so will
Mhm.
I.
Yeah, yeah. Any more questions?
Well, thank you all for taking this hour out of your day. If you have any questions that you think of afterward, I know that they can put my information on the screen also, and you could write it down so
Mhm.
that you can reach out to me with any questions or concerns.
Bonnie, we are so grateful to you. You help so many people, and have done that for so many years, and we just appreciate your dedication. So, attendees, please use Bonnie as a resource. She is a true angel and helper. So, thank you all.
Thank you.